Connected by purpose, driven by passion. This is Children's Healthcare Canada's Spark Live webinar series.
Children's Healthcare Canada would like to thank our Keystone funding partners for their ongoing contributions that support all of our programs and activities, including this Spark Live weekly webinar series. Spark Live is where we gather each week to curate, convene, and showcase excellence and innovation from across the child and youth healthcare community. Our goal is to spark conversation, ideas, and action. There are two options to join in on the live conversation. Questions and comments for our panel or presenters can be typed into the question box, or comments that you want to share with the audience can be typed into the chat box and be visible to all of the attendees. For those of you on Twitter, tag @ChildHealthCan on any webinar-related tweets or use the hashtag SparkLive. And to keep up to date on all of Children's Healthcare Canada's webinars and other activities, be sure to sign up for our weekly Spark Bulletin by visiting our website at childhealthcan.ca.
Hello everyone, and welcome to a new year and another edition of Children's Healthcare Canada's Spark Live webinar series. I'm Paula Robeson, your host for the next hour. Children's Healthcare Canada acknowledges that our offices, located in Ottawa, are on the unceded, unsurrendered territory of the Algonquin Anishinaabe people. We recognize and deeply appreciate their historic connection to this place. We also recognize and are grateful for the contributions that Métis, Inuit, and other Indigenous peoples have made, both in shaping and strengthening this community, our province, and the country. Today, we're delighted to bring you the Unclosable Hospital, Telerounding, and its implications for children's healthcare. Just a reminder that we record all our webinars, and as mentioned in the introductory video, please type your questions into the question box at any time. I'll prompt you via the chat as well. I will pose the questions to our speaker at the end of the session. And I'd like to introduce our speaker today. Paul Young is the Administrator for Community Hospitals West Health PEI. He has worked in healthcare for over 15 years in both public and private industry in several provinces across the country. Paul holds an MBA in Innovative Management from UPEI and is a certified health executive from the CCHL and completed an extra fellowship through the Canadian Foundation for Healthcare Improvement. It's my pleasure to pass the mic to Paul.
Wonderful. Thank you very much. I hope everyone can hear me okay. I certainly want to just take a moment and thank the Children's Healthcare Canada network for this wonderful opportunity to come together and share a little bit of our story with you today. It certainly has been a story and a long journey for us. One that really we had no probably solid appreciation at the time of what we were really trying to do and what impact this would have nationally and internationally. So my hope today is I'm going to tell you a bit of a story, a journey that we went through, some of the challenges that we had to overcome, and where we are today as it relates to this program model, and a little bit of discussion as we consider implications for children's healthcare as well. Just give me a moment here. There we go. So quick disclosure. So as mentioned, I am an employee of Health PEI, and Health PEI does have a software licensing agreement with Maple for telerounding services at Western Hospital. Health PEI also has entered into a research agreement with Maple to complete an academic study. And as an employee of Health PEI, I have no personal or paid contractual affiliation with Maple. I think you'll certainly hear me speak about them as a vendor with some significant enthusiasm and passion for what we've done together, and certainly hold them in the highest regard. But just wanted to make that clear before we started. So for those that are not aware, a quick glance at Health PEI. We are one single health authority. We're very fortunate that way, right across the province. An organization of about 6,000 employees and growing, spread over about 49 community sites, encompassing about 230 physicians and specialists. Health PEI right now is in the middle of a very significant transformational reorganization. So something that had begun many months ago, but is now in action. And we're really excited in terms of where this transformational journey will take us and our ability to deliver care on PEI. So a little background. Western Hospital is located in a small town called Alberton. For those that maybe are more familiar with Charlottetown, the city center, Alberton is located about 150 kilometers northwest of Charlottetown. It is predominantly a fishing and farming community. The hospital itself is a 27-bed rural community acute care site, which would be very similar to any other rural hospital that you would find across this country. We have an emergency department. We have a collaborative emergency center. We have a number of services from diagnostics, lab, OT/PT, pharmacy services, and a number of services that are shared with our other community hospital located about 15 kilometers away. Western Hospital itself is the acute care center for the region and services a population of approximately 15,000 residents. Traditionally, patients were cared for by a shared call between all physicians within the region historically. Through the entire complement, these physicians who managed a full family practice, they all typically supported the local emergency department as well as provided inpatient coverage, sometimes to multiple hospitals. They had responsibilities to long-term care. Some did some support to our community care facilities, as well as home care, as well as some other programs within the area. They've migrated from an in-person model to a hospitalist type model, share and call a week at a time, and they would take responsibility as well for all unaffiliated patients within our facility. Any gaps over the years within coverage would be supplemented with the support of outer region or outer province locums. And that worked for a number of years. And then when we slowly start coming into 2015, 2016, we knew we had a very significant challenge ahead of us. We have a regional complement of approximately 10 physicians. At this point, in 2015, 2016, we had ongoing 3 vacant physician positions in our complement. We had 2 physicians that identified their pending retirement in 2017. And then we also had 3 other physicians that had identified they're close to retiring, but would step back from inpatient responsibilities. So when we do some quick arithmetic here, that leaves us with 2 physicians in 2017 that would need to continue to support their own family practice, the emergency department, which they were already doing, some long-term care support, as well as sharing the inpatient responsibilities for 27 patients. It was certainly an unreasonable task, but one that our 2 physicians, and they were a husband and wife duo, that committed day in, day out that they would provide as much sustainable access to ongoing care until set time that we could secure enough locums or some permanent replacements for our recruiting challenges. Very quickly, we were calling in anywhere from 16 to 17 different locums every month. And our locums, as any system, we certainly had burned them out, and they were becoming more difficult to secure. So in 2016, now going into 2017, we knew that right around the corner, the prospect of a hospital closure was our inevitable fate. We had a very daunting task of needing to secure enough physicians to stabilize their services, but the lone 2 physicians we had left had identified that they had a very small window that they could keep this pace, and it was certainly unreasonable for them to do so, but they were committed to trying to buy us a little bit of time. So at this point, very clearly, we had an unsustainable inpatient care delivery model at Western Hospital, some really aggressive timelines for where we were looking in terms of our inevitable fate, and no solutions available at this point that we could find. So our team, we had done jurisdictional scans throughout Canada in 2014 and again in 2016. And then in 2017, we were hoping third time was the charm, and we broadened our net this time into the UK, into the US, and into Asia, desperate to identify whether anyone has been dealing with similar circumstances had found that secret sauce. And what came back to us was two ideas. One, the utilization of physician extenders, nurse practitioners, or physician assistants, and what would that look like? And the other one was the application of information and communication technology, and what would that look like? So when we sat down, now coming into 2018, looking at all these different options, working with all our stakeholders, trying to identify where government support was, we had three goals in mind. One, we needed to find or secure a program model that would bring stability to inpatient coverage while still producing a consistent, high quality level of care. We were going to proceed with the application of an information communication technology solution. And that in order to do this, we needed a high adoption rate, both from staff and from our physicians. And ultimately, the model we chose needed to provide safe, effective, quality level of care, and without compromising our patient experience. That was our task at the time. And when we came to this point, we were about, I would say, less than 90 days away from potential inevitable closure. That was the date when our lone two physicians, we had run out of locums, we had no more commitments, and government gave us a hard, fast date. And we were watching a few other hospitals across the country in similar circumstance that were closing. And so we could see what was coming our way. So when I look at this slide here, it's a mere, I think, small representation of some of the really prominent challenges that we were looking to overcome when we're talking about doing something a little bit differently than had been done in Canada to this point. Cultural resistance to change, first and foremost. So we're talking about a small rural facility, a small rural community who generations of family would have been accustomed to seeing the same physician. These are physicians that would have been in the area for 40 plus years. We have senior staff within our building that have practiced in a certain level of rural medicine that are quite opposed to change. And for example, it's well known in the facility that cheese biscuits will come on Tuesdays and Fridays. And God help us all if there's some interruption in the kitchen that's not possible. Folks enjoyed, and they became quite normalized by how business went within that facility in the past. So the idea of shifting any type of model was quite significant for that facility, let alone the province. The legislative, regulatory, and legal barriers were overwhelming in terms of looking at our Health Information Act, provincially and federally, and all the regulations that identified barrier after barrier why something like this could not take place, and overwhelming legal barriers as it applies to the components of our legislation that we were trying to understand how we would be able to overcome or work within our guidelines of our Health Act or our Health Services Payment Act. The physician reimbursement and funding models, where we were talking about looking at introducing a new mechanism for how we would deliver care that is not established within our province under Health Services Payment Act or under our master agreement, that also would have implications federally. So those were some really heavy items that we needed to dig in on the policy side. Meanwhile, we needed to look at how and what infrastructure we would need to invest into our facility. If we were looking at doing some sort of information communication technology-based solution, some sort of telehealth virtual care application, we would need to quickly procure all the equipment and the infrastructure in the building to be able to do this. We didn't have Wi-Fi within our rural hospital. It wasn't something that had previously been prioritized. So even looking at the application of how our connectivity would be established was going to be new for that facility. And then we come into looking in terms of a model that is new in Canada. So we were looking at this, desperate to find someone that had done this before that we could use as a reference or build off of their learnings and understand where their challenges have been and allow us to act quickly. But there weren't any, and it was difficult to find those in other jurisdictions that had varying telehospitalist models, but not like we were going to do in our facility. we had engaged, and I'll speak about Maple and the partner that we ended up working together on this model with. They certainly had some experience in the virtual care space, direct to consumer and primary care, but certainly not within a hospital setting. We were looking at very significant privacy and patient data security challenges with looking to develop a new proprietary platform that would need to be vetted and approved and compliant with existing privacy legislation and security regulations within this province. Our workflow design was huge. We very quickly had to look at understanding every movement from the moment a physician walked on our inpatient ward until they left, and capturing every inch of that flow, all the referrals and the consultations, all the interactions, how that was done in present state. And then we had a very daunting task of trying to envision, without having seen or being referenced what this would look like, develop a future workflow, understanding, assuming this works, assuming we can build it in time, what would that workflow look like if we added a level of virtuality to this? It was exceptionally difficult to conceptualize something that we didn't necessarily understand ourselves at the time. The technology itself, we partnered with a vendor that had a platform that was applicable on a consumer basis side, but certainly not that would work on an inpatient unit. So we needed to look and work with this vendor to develop a new platform, building off a foundation of what they've had, but something that ended up being a complete redesign and redeployment for the purposes of this project. And then, as I mentioned, the IT infrastructure. So bandwidth implications unknown. There was no white paper with this company. Firewall concerns, untested audio-video components. The list goes on. And when we were looking at this, the task was so daunting to our project team that we said, listen, if we're that deep into this right now, the application of using peripheral devices like digital stethoscopes, either in real time or pre-captured sounds, would certainly be of some value. So we said, you know what, we're this far into it. Why don't we look at piloting this at the same time? So we had a subset of our team that was working on that component. And then as we evolved the project, we are very fortunate in our province to have a provincial-wide electronic medical record within our hospitals. So we looked at the idea of wanting to have our physicians, wherever they would be able to connect in and chart directly into our electronic medical record and use our order sets, and in real time be able to avoid any duplication using another EMR and operate as if we would have a physician directly in the building. So we went forward with trying to pilot VPN access with our EMR with 10 different physicians across 6 provinces, all with what was really fun, varying MacBook operating systems, which each presented a very unique challenge in themselves. And then we did this, not by choice, but out of necessity, amongst an RN shortage in our region. We were down about 50% of our complement amongst vacations and in the middle of summer. And then all this kind of came to head. As I mentioned, we needed to do this at this point, and this was done in about 88 days, only because on day 91, our physicians had at this point committed close to a year and a half of being the only 2 physicians essentially providing care in that hospital for those 27 patients, plus managing their practice, plus keeping the ER open, as well as all the additional responsibilities that they hold within the region. Really, for us, at the end of the day, we looked as we started this project, and certainly applicable, I think, to a lot of the pieces of work that we all do, was understanding, for us, then, the necessity and the why at this point. Our consequence of failure was a massive driving force for our teams to work around the clock, literally around the clock for those 90 days to pull this together. The alternative, we were watching, there was an announcement, I believe, in Nova Scotia about another rural hospital that was closing just as we started this project. So there was no need to remind anyone what potentially may happen here if we don't succeed. So we certainly had everyone firing their energy in the right direction. Physician champions for this, our medical society was very supportive, knowing that we needed to do something different. We could not continue trying to solve the same problem the same way. All our physicians, except for one, were located outside of the province. The one physician was a very open-minded, progressive physician, and just happened to be the president of our medical society. And we were all hoping to secure at least one local physician to join this program from inception, knowing very well if it worked, if we could, gather their feedback, they would certainly help spread the word and encourage other participation. Because our big vision was that eventually we'd be able to secure a large physician panel who has capacity within our province and not be as dependent on physicians located out of the province. So having physician champions certainly ended up being a huge advantage for us as we went forward. Full government support. And our government was exceptionally open to saying, anything you can do to keep that hospital open. We do not want to see our hospitals closed, though we are tired of dealing with the same issue over and over again. So as much as they did not want to see that hospital close, we had a full green light to do whatever we could with whatever resources we could muster to try and put this together in the time that we did. And then communication was huge. We have us in a small rural area. We have the anxiety amongst our community groups and our staff in regards to what the future will look like. Foundations, auxiliaries, other government agencies. We met on a regular basis, and in some cases daily, just to provide the updates. And in some ways, it became a little frustrating because we felt sometimes we were communicating more than we were doing, knowing that we were on such aggressive timelines. But it was vitally important that everyone understood where we were, what would happen if we don't succeed, what we needed from them in terms of messaging, and all work to ensure we had a shared understanding of our challenges and how we're going to get out of this mess, and potentially how this may help avoid this from happening ever again. And that was big for us. And that's where the staff investment in this project comes. The staff were absolutely determined and connected with the idea. If they could make this work, not only do they provide a new opportunity for this facility to help stabilize its services and rewrite a chapter of its history, but potentially would be able to help other jurisdictions that we know we're struggling with these challenges. So the provider, Maple, was our white knight. Maple, some folks may be familiar with Maple. They're a Canadian technology company. They developed a virtual care platform in 2015. They're now in every province in spades, and they've been in news quite a bit with a lot of the work that they've done. But at this point, in 2017, they were still a very small scale startup. As the story goes here, we were waving the white flag and identifying the government about 4 months before we were about to close that, we're out. We've talked to U.S. providers. They can't come into Canada because of legislative barriers. There's no way. And there was an article that was being aired on CBC with the CEO, Dr. Belichaz, identifying that they were just coming into PEI with their direct-to-consumer primary care platform. And lights went off and said, listen, if they meet, they must be able to meet our provincial and federal privacy and security regulations and legislation, that I wonder if they may be open to doing something like this. And after a few days of reaching out, had a meeting with Dr. Belichaz and presented the idea, saying, hey, you guys have a great concept. Would you ever consider pivoting and entering into the public space? And within the next 5 days, Dr. Belichaz took a red-eye flight to PEI. We mustered our senior leadership, as many as we could get. We co-pitched the idea, and right after that, we were off to the races. So they are quite a scrappy little company at the time, but the partnership that we've had with them, with private industry, has been instrumental in terms of our success and establishing our path forward. So what was the model in the end? So telerounding. So we went live about 2.5 years ago with what was the first in Canada telerounding model. So essentially, we were using a telemedicine platform to facilitate inpatient care, leveraging physician capacity in other provinces. So in the picture on the left is Bev Ashley. She was our clinical lead on our medical unit. The physician on the screen is Dr. Brett Ball. He was our physician on day one. That's a picture just before we started this 2.5 years ago. And essentially it is what you see. It's a mobile cart with a 32-inch TV, high fidelity mic, a webcam. We have, you'll see Bev's laptop with our EMR that's opened up and available. And we have, we started this journey with this new level of technology that had evolved itself to be able to upload files and upload images, upload audio files, such as, from our digital stethoscopes, we were able to work hand in hand with Maple as they developed this technology. And then using this in tandem with our electronic medical record was instrumental. But the platform that Maple built as well acts as an EMR for facilities that don't have that opportunity. So you get the best of both worlds. And so what does this look like? And so this is happening today and has been happening in this facility for the last 2.5 years. So every day, Monday through Sunday, it is the same. So our team at 7:30 does their bedside rounding. At 9 o'clock, our Maple physician from wherever they're located. Now, when we started this, we had 12 physicians, 11 were scattered across the country. All of these physicians now are located here on PEI. So when I talk about the buy-in and the adoption and the interest that this had generated, when we had one physician on PEI that put their hand up and said, this actually works pretty well, and I like it. And all of a sudden, very quickly, we had other physicians say, I'll give it a try. I have capacity. And here we are. So our clinical team the night before would identify on a list which patients need to be seen. Of course, we do have some patients awaiting long-term care placement and don't need to be seen every day. So on average, they would see 12 to 14 patients. Maple doctor would log in at 9. They would review in our EMR some of these patients. At 9:15, they would connect in with our clinical team. They would have a discussion about a 15-minute huddle to talk through some of the patients' conditions, kind of prioritize the telerounding, and then they would initiate at 9:30. So essentially what happens is the clinical staff will take the cart directly into the first patient room. They will set it up at the foot of the bed. They will, introduce and welcome themselves to the patient. Patients are quite familiar now with this in the facility. We'll then engage the physician to come up on the screen, and then it's just as if the physician was there in person. So the registered nurse acts as the hands of the physician. Otherwise, they're able to have just a regular interaction in real time. Our physicians are able to go through their EMR. They're able to order and arrange any referrals or consults or any medications. And we do that for as many patients as we need to in the morning. It usually will take about 3 to 3.5 hours to see anywhere from 12 to 14 patients. So compared to what we typically see with inpatient rounding, it's extremely efficient and effective. And what has been very advantageous to us is we have a lot of shared resources. For example, our pharmacist is shared between 2 hospitals. This technology, as Zoom and other video conferencing technologies, we're able to connect in other providers. And if there's a real-time conversation to be had with our clinical lead and our Maple physician, maybe we'll add our pharmacist in on the screen, maybe an OT as well, or a social worker. And we'll either have that with the patient and the family, or we've done that with case conferences, or we'll just do that back when we get back to our virtual room. So once this is all said and done, the doctor and the staff will have a wrap-up huddle, and then we just continue business as usual. One of the questions that continues to come up, and a lot of times that I provide this presentation, is to say, well, what happens if something acute happens? The only other physician in the building is in our emergency department. So when you go back before telerounding, what would typically happen is if a physician came in and they rounded on their patients, they would often then leave, go back to the office, and there was an agreement that the emergency physician would support any acute needs. So the flow, how that works today, it's not any different. At any point, if there's any hands-on acute needs needed by a physician, our emergency department physicians would jump right in and manage that. What is very unique with this platform, and was really a tremendous value add, was when we look at the platform, yes, video conferencing is available. We have a really great patient profile that was developed that can act as an EMR. The live video stream works really well to have multiple providers or other peripheral devices added to it. The back-end messaging was amazing. So we encountered a problem right off the bat where, once our telerounding physician was done, we needed sometimes there'd be a lab work that would come back, and maybe there was an elevated potassium level. It wasn't urgent, but at the same point, we didn't want to interrupt our emergency department physician, to take that or to field that question. And we wanted to try and understand, to say, how can we continue this relationship, though as a facility, we're paying for a service for 4 hours. Afterwards, our physicians are no longer responsible for these patients. What Maple had done and what we were able to do is they built this back-end messaging system that was encrypted that would allow us to send a quick question to the physician that rounded. So these physicians typically would do this in between of other work, or, if they're coming in from Alberta, perhaps they're doing this before they go off to pick up an emerge shift. They would send a message, thoughts on your potassium level. It's all encrypted. It would ping their phone. They would be able to look at it and they give a quick response, knowing they're very familiar with the patient's case, or they would say, hey, you know what, I'm tied up, or no, you need to take that to the emergency physician. So what we were able to find with this system, it happened very organically that our physicians wanted to continue to field these questions. They didn't happen often, but they happened often enough. And it was quite effective that for the most part, we would be able to get a quick answer and we wouldn't have to interrupt our emergency department physician, and it worked for everyone. So when we look at the numbers, as I said, the program launched back in 2018, August 7th. We're almost 2.5 years to the date. I think that'll be on Friday. To this point, we've done about 12,000 virtual consults complete in the building. So from a contextual standpoint, up to this point, the most telehealth or virtual care PEI had done since 2008 was roughly about 6,000 consults. So we've obviously put a pretty big dent in that number, and the application of virtual care, let alone this model, was still fairly new within PEI. So we've done this on about 900 unique patients. The length of stay and remit rate. So when we look at some of our clinical indicators, and we certainly had quite a few of them, a lot of the evidence would not directly relate to whether telehospitalist models can produce or typically result in a higher or lower clinical indicator. What most of them would say were that it typically is net neutral in terms of its difference. So it's not necessarily producing a better clinical result, but it's not producing a worse clinical result than compared to in person. And that's exactly what we saw. So our length of stays, our remit rates are all consistent with what our other in-house providers are currently doing and have been doing in the past, and consistent with the province. What was really surprising and our biggest unknown was our patient satisfaction. We went into this hopeful that it'd be well received, but we weren't sure at the end of the day. Our overall patient satisfaction was about 92%, which was fantastic. What was really interesting is about a third of our patients rated it as a better experience than in person. So we had to unpack that a little bit, and we met with that group and asked them the question, and what they came back to tell us was that they felt they had 100% complete and undivided attention from the physician, because they're at the foot of the bed, they can't run away anywhere, they're not being interrupted by anyone, and they had them for as long as they need them. They were looking directly at them with nowhere to run. So they felt that they had this really great connection with their providers. In terms of patient experience, here's an example where I think Julie summarizes it pretty well, where she had an experience a few years ago. She had about a week and a half in the hospital. And she quotes, she's like, I thought it made a lot of sense, especially being out of the country and with the shortage of doctors here on the island. I thought it was an excellent experience, she said. And she goes on to say, they were right there in front of you on the TV screen. I could see them. They could see me. He had all my charts from 20 years ago. He knew all my medications. It was just top notch. And that was generally the consistent theme that we've had from most of our patients. We were holding our breath on day one when we brought this into our patient rooms, and they were prepped, and we had been speaking to those that were going to receive care this way on day one. And it seemed to go pretty good. And it was our day two that we thought, okay, you know what? I think this is going to be well received. And the first room we went into, the patient at the door said, no, you can't come in. And our hearts dropped and thought, okay, we thought there was going to be pretty good adoption. And she finished by saying, oh, but no, I just need to put my makeup on. If I'm going to be on TV, I need a moment to get ready. And that's where our TV doctors came from. They were so excited to see the TV doctors because they felt they were going to be on TV, and it was this great connection. And we were able to relax and said, okay, it's more than just this new experience. It's one that a lot of our patients and residents in the hospital were really excited for. So in terms of successes, when we look at this, we had a successful implementation of our model. We had really high adoption and satisfaction rates from our staff and our patients. We've had 100% uptime. And for those of us that are involved in a number of technology-based solutions, that's rarely heard of. So here we've had a platform that we've had zero downtime with, especially considering it was built from scratch. And we only saw it live for the first time 3 days before we went live, and had to build our training around that within the last 48 hours. So Maple did a tremendous job to get this up and ready for us in such a short period of time. The integration of wireless devices worked really well. The stability is key, because we presented this as a temporary model, and so that we could continue to actively recruit into the region. Over the last 2.5 years, we've now recruited 6 new family physicians, with our last one, we believe, is going to sign this Friday. So that's taken us from a complete point of instability to having now positioned ourselves that we have a full complement within our region, and we will no longer need the support from this model going forward. But at the time, when this model was in place, immediately our few physicians left were able to give up their patients for a weekend, put them in the program, and take a breather, which is really important to get some downtime for our physicians as we tried to bring some stability into our region. We were able to also launch a new model and bring a nurse practitioner into the facility to take care of the patients awaiting long-term care placement. But our local physicians didn't have capacity, they felt, to be the collaborating physician. So we were able to organize that collaborative relationship with our virtual physicians, and that worked really well. And at the end, the interest from this program has been great. We certainly never appreciated the reach that this would had. I found myself in Vietnam last year, presenting at a healthcare summit that I think we had about 40 countries there across Asia. They, at the time, had about 400 plus hospitals, rural hospitals, on the brink of closure, because they could not figure out how they could redistribute their physician population to prevent the closure of these hospitals. So we had this opportunity to go down and present our story and how we did this, how we did it quickly, and how we thought that it could work for them as well. So right now, I'm still working with a number of countries across Asia to help support the application of this model. Now, children's healthcare, I love this picture. Telerounding, when we went live in 2018, it has now been the first of about a dozen different models that we've put in place within our region. This is one that we put in a virtual care pathway in our emergency department that went live in February 2020. We understand it to be the first in Canada at that time. And that little Ava here with her mom, Michelle, was one of our first patients that morning. And when we talk about the implications this has and virtual care has on our patients' experience and a lot of the challenges and barriers that exist, here's a great example of how something can make such a subtle difference. So Michelle is a parent of little Ava here, who's about 2 and change, and she wasn't feeling well, and she couldn't get in to see her family doctor that day. Michelle had to take a day off from work, came into the emergency department at 8:30, was told at that point that she would have about a 9-hour wait. She would be losing an entire day. Her grandmother could have watched Ava, but Ava didn't want to go to the hospital without her mom, so it was a very trying challenge. And in a situation, very stressful situation for everyone. And of course, Ava's not feeling good, and mom's trying to figure out what to do with her in a busy wait room. So we went live this day with our virtual model in the emergency department, and we gave the option if they wanted to try this new model. And within about 5 minutes, Michelle was able to register on our Maple platform. And 5 minutes later, Dr. Mako was on the screen and facilitating the encounter, supported by a registered nurse. And that took about 10 minutes. And at the end of it, I believe Ava needed some antibiotics, which was electronically prescribed directly to her pharmacy that Michelle was on her way to go see. So what otherwise was about a 9-hour wait at that time, we brought down. I think they were in and out in just over 30 minutes. So that in itself has had a tremendous impact on our ability to manage flow within our emergency department, impacting the overall wait time, but certainly these individual wait times, giving another opportunity to help enhance the experience. So in this case, Ava was supported. Michelle was going back to work. Ava was going to stay home with her grandmother, and it certainly helped mitigate a lot of these challenges that we see that can be alleviated with the application of virtual care. And then when we look at some of these further applications, as it impacts, children's healthcare, the on-demand, I think where COVID has taken us now and has really propelled our country in a let's figure out how we can fast track virtual care. We've seen that, of course, explode in every different which way. It offers this new level of flexibility that hasn't been there before. So when we look at flexibility for the story like Ava to come into the emergency department, to the applications now that we have in this province, we've expanded that for unaffiliated patients at home so that they're being managed and supported at home at a time that's convenient to them. So keeping that flexibility, I think that opens up a lot of pathways for our patients and for our children. The travel and transportation is a huge challenge for not just folks in rural areas or rural and remote, but certainly urban areas as well. And we look at the travel time and the implications, or in our region, rurally, about a third of our population don't have access to transportation to even get to a doctor's appointment. So looking to overcome some of those barriers, or of course, transportation to go see a specialist is always a challenge that all provinces have to deal with and try and mitigate. The time away, as I mentioned, the impacts to school and waiting in a doctor's office or an emergency department for a long period of time and missing school, yet being able to have this facilitated quickly. And depending on the need, either returning to school or the parents returning back to work, and the inconvenience of waiting, certainly in an emergency department for 7, 8, 9 hours your entire day, and losing that time and the impact that has on your own experience and your family's experience. So I mentioned the patient's experience is night and day when we can offer these mechanisms where we can offer care differently than what we've done in the past, being in the comfort of your home or connecting with a specialty service that otherwise wasn't available to you that would mitigate the need to travel. Specialty care is a big concern where we're looking at connecting with our radiation oncologists and our cancer care team for patients. Initially, we were looking at this at the hospital and to connect them at home. Again, it's all about now bridging that gap, and we have that ability to do so between our patients and their providers and removing all those geographical barriers. And the peace of mind, right? The peace of mind that this offers, these new solutions from the old approach that we took healthcare delivery to now being able to do it in a way that is much more flexible, on demand, as needed, and responsive. And knowing that's available to us all, I think brings a lot of peace of mind. And then, an electronic medical record, we've seen this quite a bit as well, that, you go through an experience and yet, a lot is happening. And I know with my own kids, you're trying to remember what the physician is saying and directions and instructions. And what we're seeing with our the applications of different virtual care platforms is that information is then available to you in a portal. So for example, for us in the emergency department, Michelle could go home, log in, and she could see exactly what her encounter entailed, what the doctor notes had said, and that's available to her. So you can just focus on supporting your child or your loved one in that experience and having the accessibility to that level of information. And I think I'm just coming up to time. So just a brief summary. Our Telerounding project was born out of sheer necessity, to present or prevent the discontinuation of services within that facility. But it certainly had became a massive stepping stone for us, that it inspired our teams to then come back and say, well, if we fix one problem, what else could we do that would not only support our needs, but the needs of the community and others across the country. So it's been a great stepping stone and a launching pad for a number of new and innovative initiatives that we've launched. And I think it really helped remind us that innovation does not have to take months and months and months. And we've been accustomed to that, I think, as a system, to looking in terms of building business cases and project charters and hitting timelines, 12 months, 18 months, and looking at why and how could we potentially do this much quicker, knowing that, we have patients and loved ones care at hand, that we need to be much more responsive as a healthcare system. So it certainly had served as that reminder to us that we can move and pivot quickly. And that ultimately, these models, can be exceptionally effective, inspiring, and influential in scaling up countrywide to both urban and rural and remote and medically underserviced communities. And there's a tremendous advantage to exploring what infrastructure needs are there, but we have that capacity within our country today. And it really goes back to the redistribution of access. And I think that's one of the beautiful assets that vendors like Maple and others are able to provide. They have the capacity and they have the technology, and it's about marrying that relationship between private industry and the public need, and working in partnership to address these gaps. I think we have everything we need in Canada to do this. It's just about, reorganizing some of the puzzle pieces to make it work for everyone. So I think that's everything that I have, and certainly be welcome to answer any questions that anyone may have.
Thank you, Paul. I am amazed at the speed of transformation in your hospital. Less than 90 days to design and implement is really impressive. We have 3 questions so far. This is my prompt for others in the room to get their questions posted in. And the first question, first the comment, this is amazing, great work. How do you incorporate caregivers into the virtual round experience? Do they need to be at the bedside, or can they connect in virtually?
It's a great question, actually. Both. So we've from day one, as we started into this, we adopted a motto: there is no box. So obviously that was one of the components that we did include some of the community members as part of our planning process, and it's an open experience for all. So if those that are at the bedside, it's as if there's a physician there. So it's just like it happens, before telerounding was available. If they wanted to participate, great. If they wanted to wait outside, wonderful. If they were not available, and we have had that as well too, where we've had others out of country that wanted to participate in the rounding that wasn't available, we could make that happen. So it created essentially an endless opportunity to say, if someone has an idea of how we can connect and involve care givers and providers and loved ones, we're able to do that, as long as the patient certainly would support that. So the technology has allowed us the ability to do that, and we do that on a regular basis.
Thank you. The next question is, do you have medical learners at your hospital? And if so, how are they involved, and what's their feedback been on this process? Oh, I'm sorry, Paul, did you hear me?
Would you mind repeating the question?
Sure, no worries. Do you have medical learners at your hospital? And if so, how are they involved with this telerounding, and what's their feedback been on the process?
Well, maybe whoever asked the question could just elaborate. I'm not familiar with the term medical learners
I think they mean
within our facility. So if could just have the context behind that.
Sure. I think it means medical students, like residents. So residents or medical students?
Okay. Well, we're a very small rural hospital, again, in a small rural region. So we do not have a lot of medical residents that came in through. And again, one of the reasons for that over the last number of years too. Now that has certainly changed its course in the last 18 months. And we actually have our first few residents with us this month, which of course are there with their supervising physician. So and that goes back to, I think, that broader picture of bringing stability within our region. We needed to have a complement where we would have physicians that, and certainly enough physicians for the first part, but the second to also start to engage and cycle through and have clinical rotations with medical residents. So we have a few now. We didn't have them then. We have medical students, medical nursing students all the time. There's lots of folks that we continue to endorse and support through building our legacy in terms of our nursing complement. And I think that raises an interesting point. What is really interesting for us, so in our province right now, we have close to 200 nursing vacancies within our hospital system. Within our 2 hospitals in the region that we've shared a lot of these innovative projects to trying to introduce stability, we no longer have any gaps in any position, physician down through nursing, through allied health, through nurse practitioners. It's a completely full complement, which when we look in terms of a lot of number of efforts that went into bringing that together, one of the pieces that we've heard from a lot of providers that have come from out of province, in some cases out of country, they have joined their team having been made aware of some of the advancements that we've put in place, some of the innovation and the culture that we've supported. And it started to attract some very like-minded individuals that were interested in doing and being part of a progressive team. And that's one of the many reasons that we've now come to a point that our entire staffing levels have been stabilized within our region as a microcosm within our province that's very unstable in a lot of respects. But within our region, our 2 facilities are completely staffed, which is it's a first that we've ever seen that in probably the 76 years those hospitals have been there.
That's amazing. There's a comment here from Ottawa wondering if you would be open to connecting with folks to briefly share some details about the virtual ER physician, because they're looking at implementing something in the very near future of a similar model, and they're piloting workflow and other elements of it. And I will share with you the email to connect if you're open.
Sounds
to
great.
that.
Thank you.
Wonderful.
Would love to.
Another question. How does this model work for isolated patients? Is the hardware brought into the room? How is it disinfected between patients?
It is, absolutely. So we worked really closely with our provincial infection control teams. And we do have protocols in place that will allow us to bring this equipment into rooms that we do have full isolation protocols in place. So that was one of the components. We wanted to explore a model that ideally would be completely inclusive and would potentially mitigate in the event that we had no physicians at all, though we had 1 or 2 that were still remaining seeing their own patients. And at one point we had none, but we wanted to look at creating a model that would introduce stability indefinitely. And I think that's where the title, which I'm stealing that from Dr. Brett Belchez. He did a presentation a few weeks after we went live with this model to Breakfast with the Chiefs in Ontario, and he labeled and coined this presentation the Unclosable Hospital to garner some interest. And it's been one of those really funny ideologies that have stuck, where we have continued to frame our focus around rural healthcare, but around system care and how we can design models that can create these levels of integration or support that in some ways are impenetrable to failure. And that's a pretty broad statement to make, but it's one that we have grown tired over the years to seeing rural healthcare continue to be reshaped out of our inadequacies to ability to staff our services and see our programs reduced and shrunk merely as a result of not being able to address a lot of our staffing gaps. And we wanted to look at models that we felt confident, regardless of what we face, could help rewrite that story. So one of those components around infection control and isolated patients would we run into circumstances where this model could not care for certain patients or patient groups. So we were able to overcome that. Was one of the more challenging ones to look at, coming to an agreed upon process that would work, and we've had that approved. So that hasn't been an issue. But when we look at population types in our hospital, palliative care, end of life, of course, are one of the most trying pieces and very controversial as it applies to being able to support and provide any type of care remotely that's not on site. So something that we're very cognizant of, and were from day one. And we looked at a process connecting with our existing physicians that would adopt and assume responsibility for any palliative or end of life patients, and we would remove that group of patients from this model, as we felt that we had options. If you don't have options, it's still not great. But we had options, and we were able to work with their medical teams to say, you know what, we have a more appropriate and compassionate way that we could help support their care, and it really shouldn't be through this program.
And are there more, you leading into the next question, but that's here, as to whether there's some patients that it isn't a good fit for? So people who are receiving palliative care, you're saying, are there any other groups that you found that this wasn't as effective with?
To be honest, in the last 2.5 years, it is the only patient group that, and it wasn't on behalf of themselves or their family. Just when we look at the mechanisms for how we can be as compassionate and sensitive to their patient experience, we had the interest and the availability from local expertise to be able to support that. So that was one aspect of it that we felt as a team would not necessarily be appropriate for delivery under this model. We haven't had any other group population types within our region. Not for me. We've had the odd patient and family over time that has said, I'm not sure about this, and they need to understand it a little bit more. But after having it done the first time, they were extremely accepting. So a little bit of hesitation out of the gate from the odd family here and there, but for the most part, once they've had that experience, it tends to be exceptionally positive. So I would limit that to just our palliative and particularly end of life patients.
And what has how did this impact your ability to respond in the time of COVID?
It's a great question. So when we looked at this model, when we launched this one in 2018 and we saw the success, we went back and as a team in our region and said, what's our next biggest challenge? And at that point, we had a health center in one of our regions that had a retiring physician that was going back to Ireland and was retiring from practicing and going back home, but not retiring altogether. So we crafted this idea of creating an international primary care pathway, connecting him back to his patients at his health center that he's worked at for the last 15 years, and whether or not we could make that work. And again, many hurdles that I discussed here today around creating that between the dualities of legislation between our province and Ireland and everything in between to create that pathway we were told was unbuildable. But we built it and it worked exceptionally well and kept that facility operating. And our physician actually started yesterday for that facility. And one of the reasons was that, this health center was doing some pretty neat stuff and they got excited about that. And ultimately it was a big part to help to recruit them. But having built Telerounding, then that international primary care pathway, and then into our ED decanting, which when we launched in February, just as COVID was really coming into Canada, it gave us this amazing foundation and acceptance within both government, within our health authority, and within the community to say, where else could we consider these needs? And that's where we ended up very quickly coming together over a matter of a few months. And then in partnership with Maple again, we put together an unaffiliated program to try and help support a lot of our patients to avoid coming into our emergency departments. Which has worked really well. So they're getting any unaffiliated patient in this province has access free of charge to connect with a physician from the comfort of their home as many times as they need. So that program is in place, and that was only available because a lot of the foundational work was done around telerounding and our primary care models, and then around the ED decanting and a lot of the issues and regulations around payment schemes and the operational logistics of it were already laid out. So that positioned us exceptionally well to be able to provide that level of support and other applications for then when the province said, okay, let's go ahead and look at Maple-ish type platforms or Zoom. The concept of virtual care had been circling around this province for the last 3 years in a lot of different ways. A lot of physicians were involved in a lot of different ways. So the idea of then saying, now you guys take this with your own family practice, it was there. So I think we had this really amazing tip of the spear foundation within the province where everyone was quite familiar with it. The culture was there. Those that haven't directly been using it, the adoption, I think, allowed us to move very, very quickly and have a really quick and significant adoption rate from a lot of our providers. So I think this all helped. Kind of the timing was probably couldn't have been any better if there's some silver linings within COVID.
Wonderful. Thank you. And I think that's the end of our time today. Thank you so much, Paul, for a great presentation. We really appreciate you sharing your time with us today. Thanks to all our members and other attendees for spending this time with us, and we hope you depart with some practical knowledge to bring back to your organization. Join us here again on February 10th at 11 a.m. Eastern when we're partnering with Solutions for Kids in Pain, or SKIP, to bring you Commitment to Comfort, Spread and Scale of a Pediatric Pain Management Initiative. And as well, you can register now for our virtual complex care pop-up on March 25th, 2021. It's called All In, Creating Synergy in Pediatric Complex Care. Visit our children'shealthcarecanada.ca website for more information or to register. And it's always great if you can watch live, as your questions and comments really enrich the discussion. But if you can't, the recordings of these sessions are made available after the fact on our Knowledge Exchange network. So thanks again for joining us today. Thanks to Paul for this great presentation. And hopefully we'll see many of you back here next week. Bye, everyone.